endometriosis affects around 1 in 10 women. That's millions of women worldwide. And on average, it takes around 7 to 8 years to get that diagnosis.
So the statistics you've just shared are very troubling.
If you've ever wondered whether your periods are meant to be this painful, or you've kind of been struggling with different symptoms, managing day-to-day life with this, then this conversation is for you. Today, we're going to be talking about endometriosis, what it is, what the treatment options are, and how you can live with this. This is Patient in the Room. Today, I'm joined by Miss Natasha Abdul Aziz, Consultant Gynaecologist at London Gynaecology, who supports women with a wide range of gynaecological conditions, including endometriosis. Welcome. So I was doing a bit of research before this kind of episode, and I came across the statistic that endometriosis affects around 1 in 10 women. That's millions of women worldwide. And on average, it takes around 7 to 8 years to get that diagnosis. During this time, many women are kind of told that their pain is normal, scans look fine, and this is kind of just part of being a woman with a period. Can you actually explain to us what endometriosis is?
So the statistics you've just shared are very troubling. Mm-hmm. And hopefully we'll get a chance to discuss why those are a little bit later. Endometriosis is where we have endometrium-like tissue, so tissue that's similar to what you find in the lining of the womb, outside of your womb. Common places that it can be found include the ovaries, places along the pelvic side wall, so the sides of the inside of your pelvis, in the space between the top of the vagina and the rectum, and in the ligaments that hold up the womb. But it can also be found in other places. It can be found in the bowel. It can be found on the bladder. We know that it can be found up along the diaphragm. In theory, whatever immune-modulated response allows this tissue to grow could allow it to be found anywhere in your body. Other places outside of the pelvis, not as common, but certainly possible.
And I guess, talking about why it takes so long to get diagnosed, I was reading there can be such a variety of symptoms related to endometriosis. What are, some of the most common symptoms that you'll see?
So common symptoms include really painful periods that are not where you're not able to manage pain using what we call simple analgesia. That would be paracetamol or ibuprofen. Pain that is disrupting your life. You're needing to take days off school. You're needing to adjust how you work. Maybe you work your holiday around it. You're having an impact on your life. You may also find that you have challenges with pain when you're intimate. You may find that you have pain when you have bowel motions, and this can be cyclical, so it's worse when you have your period, and then it's not as bad when you don't. You may find also that you have some pain when you're passing water. You may find, again, cyclically worse. You may find that you have bloating. And then you might find that you, over time, develop a more chronic low-level pain that then worsens in a cyclical pattern.
And when we talk about pain there, I feel like a lot of the time, pain during your period, it's kind of passed off as normal.
Yeah.
When it's affecting your day-to-day life, that's when someone should maybe be seeking to go to a doctor
Yes.
around that.
Yeah, absolutely. I mean, the number of women that I see that tell me, oh, I was just told, this is what periods are, or a woman's role is to suffer and we just need to put up with it. We just have to be resilient. Work wants me to be productive. Those really aren't acceptable excuses anymore. If you have pain that is affecting the quality of your life, our job in the medical community is to see if we can identify what's causing it, Sometimes we can, sometimes we can't. But regardless of what the outcome is, our job is to help.
And in terms of bloating, so I know a lot of women can feel quite bloated, a little bit sluggish on their period. What's like an abnormal level of bloating that might be as concerning?
That's a good question. I don't think I mean, as long as a piece of string, really. So if for me, bloating, yes, can be part of the normal hormonal cycle because progesterone slows down your bowel movements, it relaxes your sphincters, you will retain a little bit more water. But if you're having a lot of bloating and it's really tender, you're changing your trousers, you're needing to wear looser trousers, it's just really uncomfortable for you, maybe that's something you should consider.
And in terms of like red flags, someone that is maybe wondering whether they do have endometriosis, what is like the biggest red flag that they should be looking for?
I think if you're wondering.
Yeah.
Because I feel genuinely, I feel that people don't walk around looking for reasons to be unwell. But if you're starting to ask yourself the question, I'm not feeling great. I'm noticing there's a pattern to it. It seems to be worse during my period. It's really affecting my mental health. It's affecting my personal life. It's affecting my professional life. And I feel like I'm struggling.
Yeah.
In addition to the physical symptoms.
And I hear a lot, actually, women coming off of hormonal birth control, they're then kind of being diagnosed with endometriosis, years later, or they start struggling with really severe period pain after coming off. Are they linked? Why is that happening?
So what hormonal birth control does, whether it's the progesterone-only pill or the combined pill, is that it suppresses normal hormonal fluctuations. Mm-hmm. So if you're on the progesterone-only pill or some form of implant, for instance, you're not having a period. And if you think of these endometrial-like tissue that might be found outside of your womb, it acts and responds to hormones the same way that the lining of your womb does. It causes a cycle of inflammation, so it releases prostaglandins, cytokines, growth factors, and hormones are able to suppress that because we're not having a change. We're overtaking your hormonal cycle with a constant level of hormone in the pill. If you're on the combined pill and you tricycle it, so you've taken it, say, 3 months without having a withdrawal bleed, you'll get the same effect in those 3 months of relief. And so that's why sometimes we see women who are coming off of hormonal pills, for whatever reason they were on it, are now experiencing pain. It doesn't mean that suddenly endometriosis is developing. We don't know when it developed, but we do know that the pill is a treatment for it.
And so just to clarify there,
it's a symptomatic treatment.
Endometriosis is not caused by hormonal birth control pills. No. Okay. It's a good distinction to make there, I think.
Yes, I didn't know that people were thinking that.
Yeah, it's searched online quite a lot apparently.
Yeah. Correlation is not causation.
And I guess if you are coming off of contraception and you're then kind of experiencing quite severe pain, what time frame should someone kind of wait for things to settle down before going to see a doctor?
I don't think you should wait if you have severe pain. Mm-hmm. So again, anything that's unrelieved by simple analgesia, paracetamol, ibuprofen, maybe a little bit of heat. These are all things that help reduce inflammation and that we might find with someone with a period who doesn't have endometriosis. If you're unable to manage, if you have used the paracetamol, the ibuprofen, but the pain is still significant, if it's ongoing, if it's stopping you from doing the activities of your daily life, I don't think you need to wait. That's something that should be looked at. And look, different kinds of pains mean different things. It may not always be endometriosis. You may be having a bowel spasm. You may have a bladder pain syndrome. You may have an ovarian cyst that's ruptured. You may have a torted ovary. You may have an appendicitis. But if you are having pain that is unrelieved by simple analgesia and it's affecting your life, have a chat with your doctor.
I feel like sometimes it can be just like so normalized, and
yes,
you know,
that's not just a feeling, that's fact. That's fact.
Yeah.
So this is my jam. Jen knows this. When you look back at who is believed when they come in with pain, we know that traditionally women are not believed, not to the same extent as men. There have been studies that have shown that if a man and a woman both attend the emergency room having a heart attack, the man will be seen sooner and given more pain relief than a woman will have. If you read Eleanor Cleghorn's Unwell Women, she will bring to light for you all of these studies that have shown that there's an absolute disparity. And we know that that disparity exists. We know that it exists even more for women of color. Annabelle Soamemo wrote Divided Racism in Healthcare and How to Decolonize It. And I think that's a really, really important book as well, because it shows us where our biases are, and they can be unconscious because we're operating within a system that gave it to us and we may not have realized it. So you need to step back and ask yourself, where did these come from? And it comes from, you know, you can go back to empire, you can go back to whose voices mattered in empire, who was treated as human, whose input was valued. You can go back to the ancient Greeks, where, you know, we call we have a term called hysteria, which originated in the ancient Greek times, which was essentially a theory that the womb would just wander around a woman's body and strangle other organs, and that's why she might be mad, sad.
Really?
Yes. Yeah,
wow.
yeah. That was the origin of the word hysteria. Is they thought it was a wandering womb, and that's why women were so unhappy.
Oh, wow.
And that's why they were having all of these other symptoms. It's because their womb was the source of their trouble. But I mean, this goes way, way back. And so I think when we have the conversation, and I think these conversations are really important about listening to women, believing women, and using listening as a really acute clinical skill, we have to accept that if we're going to do that, we need to open up the conversation and say, where's our bias? You know, do we listen and appreciate equally for both men and women and people of color and people of different faiths and cultures, people who don't look like us? It's just such an important conversation. And once you change the structural bias, I think then you'll start to see more of a change in how doctors are taught.
And if someone isn't being heard by their doctor, so they do have a lot of pain, scans are showing nothing. Do you have any like practical tips for someone to advocate for themselves when they're having that conversation?
Bring someone with you. That can sometimes help. Pain is a very emotive thing. And sometimes when we're talking about it, we might get overwhelmed. Maybe we're missing some of the key elements that your doctor is looking for. And again, I don't ascribe to the notion that you have, they probably do exist, but it isn't one person who has this desire not to help you. I think it's just the training and who we believe and what we look out for and what we want to hear to say, oh, we should move on to investigate further. A negative scan doesn't mean that you don't have endometriosis. So an ultrasound scan is wonderful. And in the hands of certain people, an ultrasound scan is as good as an MRI or a laparoscopy. There are some very specialist clinicians who scan who will be able to tell you, I see endometriosis, even if it's not very large or of a huge volume. But by and large, on ultrasounds, you won't see superficial endometriosis. Superficial sounds like a derogatory term. What I mean by that is endometriosis tissue, it's like a little spot or a pearl, sometimes white, sometimes black, and it can be just sort of stuck to the peritoneum, which is the lining on the inside. It's tiny, and ultrasound cannot always pick that up. So in general, in the past, what we have always said, and this is a point of contention, so I know some people will come at me for this, but, you know, even if you look at ESHRE, which is the European Society's guidance, and NICE, there are slight differences. But in the past, we've always said that the gold standard for diagnosis is a laparoscopy. That's a keyhole surgery where we look inside your abdomen and pelvis. We physically see the tissues in real time, 3D, full color, and we go, yep, here it is, or here it isn't, or this is what's happening. As more people have been becoming more advanced with ultrasound, and also as we have radiologists who are becoming more advanced in their training with reading MRIs, those are two additional or potentially alternative ways to make the diagnosis. NICE, which is 25 years ago when I was just a medical student, I sat in a room with people talking about NICE guidelines, and I went, oh, they're all so polite. They just keep saying these guidelines are so nice. And so it's the National Institute of Clinical Excellence. I've come a long way. I've come a long way since then. But just in case anyone doesn't know, so the National Institute of Clinical Excellence, which allows us and gives us funding and gives us guidance on how to operate after doing evidence-based assessments and also financial assessments. They say you can make this on the basis of a clinical diagnosis. So your symptoms are very suggestive. So I think there is a lot of ways to get validation and recognition for your pain. I think it's really important that people understand endometriosis and also understand that it's multifactorial. So one person's pain is different from another person's pain. Severity doesn't always correlate with what we see on imaging or at surgery, which again, a lot of people will tell me is absolutely the gold standard. What are you saying about imaging? But, you know, it's a discussion. And I think what's important also is that maybe the history, the investigations don't show endometriosis. It doesn't mean that you don't have the pain. It might mean that you have different varieties of the pain. There are, Carolina Afores is fantastic, and she does a great talk on pelvic pain. And she makes it really clear that you have the inflammatory pain that can come from these bits of tissue that are outside of the womb. And this inflammation causes pain and generally responds to non-steroidals like ibuprofen and hormonal suppression. But then you can also have neuropathic pain, which is different and won't respond to those as well. And neuropathic pain can happen when you have maybe scar tissue that's formed as a result of inflammation, near a nerve that's kinking a nerve. We know from starting to do more research now that these little implants, these endometriotic deposits, they do something called neurogenesis, which is they create nerve cells. They're diabolical.
Wow.
Yeah, or they recruit nerve cells so that it's almost like they want the attention. You know, they're just like, look, this is going to be painful, regardless.
Yeah.
But that neuropathic pain, that can be difficult to solve, and that won't be solved by surgery, by hormones, by standard painkillers. Then you have this idea of central sensitization, which is, it's a neuroplastic change. So it's the way that your brain responds to pain changes. The volume just gets turned way up. And all of a sudden, what used to be a normal stimuli for you is amplified to the extent that now everything feels painful. And that can happen if we don't manage to intervene in the pain cycle earlier. It can happen with people with chronic pelvic pain. And that's why, it can be such a trial. And then the last thing that she mentioned is the musculoskeletal pain, which is, if you think about yourself and when you're in pain, you're really holding yourself. You're holding yourself tightly.
Get quite tense, don't
Yes,
you?
and then there's also smooth muscle, which is muscle that's not under your direct control, but it does that because the body protects where it feels like something is hurt. And so you can have musculoskeletal pain as well. And those different types of pain would be managed in different ways. It's never going to be a one size fits all.
Yeah.
It really, really depends on you, where you are in your life, what your symptoms are, what you want to achieve, what your goal is. Yeah.
Sounds like the kind of treatment options for someone with endometriosis is such a broad range of different options. It's so individualized.
Yeah.
Yeah.
So, I think if you look at NICE's advice, or the BSG, which is the British Society for Gynaecologists, that's it's a society that helps to advise and manage gynecological surgeons. Their advice is that if you have significant endometriosis, you should be managed in an endometriosis centre, of which there are a handful in the country. And that's because in those centres you have access to a multidisciplinary team. So you'll have an endometriosis specialist, nurse, as well as a surgeon. You may have bowel surgeons, you may have a urology team, you may have a physiotherapist, you may have someone from the pain team. And that gives you this full spectrum of support for different ways. We don't have that option at the moment for everyone in every department, but looking at it as multifaceted, I think can help, particularly if you've tried one thing and it's disappointing that it hasn't worked.
And in terms of living with endometriosis, what's kind of like a reasonable adjustment that we can expect from a workplace, say, or from a school, to kind of help that person?
I think that the most constructive conversation that you can have is with your line manager, your colleagues, and your doctor, or potentially with the occupational health nurse in your department where you work, if you have access to that. It's probably going to look different for everyone. Yeah. But reasonable adjustments according to the Equalities Act in 2010 that was updated in 2024, recognizing endometriosis as a chronic condition if it has debilitating side effects for you, might be where you consider flexible hours, adjusting according to when you're expecting to feel more pain, having the ability to work remotely. Those are conversations that can happen, and that you have a right to happen if you suffer from a chronic illness.
And approaching a conversation with your boss, I think that can be really daunting. Like it's quite a personal kind of thing. Do you have any tips or suggestions of how to kind of start that conversation?
If you have occupational health, go to them first, and they will give you a framework for how to have the conversation. They're going to ask you how this is impacting your life and your work, and they're going to find out if you have the protected characteristics that can be supported through employment law, and they'll tell you this is how you might be able to approach this. You are not required to divulge your personal medical history. You can say, I am struggling with a chronic illness. It's up to you if you want to share more. Sometimes in context it might seem reasonable, but you don't have to.
And in terms of kind of living with endometriosis, looking towards the future, if you wanted to have a baby, can you have a baby whilst also having endometriosis?
Yeah, you can. Now, in medicine, we tend to look at things in two ways. We look at the effect of the person and living on the illness, and then we look at the illness and its effect on that person's life.
Mm-hmm.
So what we do know is that anywhere from a quarter to half of women who are being seen and supported to have fertility treatment, we will find endometriosis.
Mm-hmm.
That doesn't mean that the reverse is true. So can you get pregnant with endometriosis? Yes.
Mm-hmm.
Can you get pregnant spontaneously? Yes. And some people will tell you if you're experiencing a lot of flares, and I think it's been quite triggering for a lot of people, actually, from what I have understood from patients, is they'll tell you, why don't you try, if you're thinking of starting a family, why don't you try and get pregnant? Because you will feel better. You won't have, if you think about it as cyclical with inflammation that's worsened with periods and with changes in hormone levels, then when you are pregnant, it's similar to being on the pill. You don't have that. You're much more stabilized. And so that it does give relief. Having said that, if you have endometriosis and you have been trying to conceive and you have been unsuccessful spontaneously, if you're under the age of 35, you've been trying for 1 year to 2 years, or over the age of 35 trying for a year, you should be eligible to be investigated for assistance for fertility. And if you have endometriosis that you know about and that we know is significant, things like adhesions, so where organs are starting to get stuck together because of inflammation and scar tissue, endometriomas, which is where you have endometriosis that collects in a cyst on an ovary, or a hematosalpinx, where you have a dilated fallopian tube that has some blood in it. Those conditions, along with a general inflammatory background, would warrant an earlier intervention. So don't wait the 2 years. Have the discussion about the intervention, and the discussions need to be really specific to you, because what is the outcome? What do we want from, say, a surgical intervention? Are we aiming to reduce symptoms? Are we aiming to reduce pain? Or are we aiming to optimize fertility? You may have very significant endometriosis and not have pain, simply because those endometriotic deposits are not in areas that are very highly innervated. So your goal may be fertility, but then we need to have the discussion with you about, okay, when we remove endometriosis cysts from your ovary, we reduce your ovarian reserve each time we do that. And so let's look at the size of these cysts. Let's find out if they're on both sides or not. Let's see if whether you need the surgery before you try for fertility. Let's understand whether you've had any pregnancy losses. It's a very, very specific and wide area to consider for you. So it will be individualized.
Before we kind of wrap up this conversation, I just wanted to kind of go through some of the most frequently asked questions that I see on social media, people are searching on Google, see if we can just give some clarity to people. So first one, super, heavily searched for. Are period pains just something that I have to live with?
No.
Is endometriosis just a bad period?
No. I think the thing I say the most in my clinic is, I need you to stop being a hero. Mm-hmm. You don't need to do this to yourself in your life. You don't need to be resilient and grit your teeth. There are ways we can help.
Can endometriosis be cured?
At the moment, no. It is a condition that even with surgical excision or suppression with hormones can return.
Is surgery the only option for treatment of endometriosis?
No. Like we mentioned before, there is simple painkillers. There is hormonal suppression. There is more complex painkillers. There is surgery. And then there is the involvement of a multidisciplinary team. So things like nutritionists, physiotherapists, and other people who can help manage.
And does endometriosis get worse over time?
Not everyone's disease course follows the same pattern, but it can. And I have seen that as a big concern of people coming in saying, if I don't find out about it now, it's just going to get progressively worse. I think what I'd love to leave here for thought is that every intervention has a payoff. And if we're doing surgery, it may be the right decision at that time. You may require more than one surgery in your lifetime. Some women have had 4 or 5 surgeries, and we start to see then that actually the side effects from the surgery are worsening neuropathic pain more than the endometriosis itself. And so sometimes what you might have a conversation with your endometriosis specialist is balancing the two of these things, the risks and benefits of different interventions. Sorry, I know this is meant to be short, but
no, it's so interesting. Yeah, definitely. And then kind of final question. If my scans are showing as normal, does that mean I definitely don't have endometriosis?
No, because superficial endometriosis often is not picked up on ultrasound or MRI. There are some people who are, Davor Jurkovic might be the best person in the world, I think, with ultrasound, and the people that he's trained. But not everyone has that skill. The only caveat I would say to that is with superficial endometriosis, they're doing a trial at the moment called Esprit. And in that trial, what they're looking at is they're doing the surgery for everyone, and when in 50% of the women, they will excise the superficial endometriosis, and in 50% of them, they won't. And what they want to see is whether there is a difference in pain and outcomes afterwards, because at the moment, again, this is a point of contention. Some people say excision, absolutely, excision is the only way, and other people are not quite so sure. So we're starting to do research to find out, is excision the best thing to do for superficial endometriosis?
For someone who is watching this episode, what's like one thought that you'd like to leave them with after watching this?
I think believe yourself. I hesitate to use the term gaslit, but genuinely believe yourself and believe in what you are feeling and know that you know your body best. And it's okay to ask, and it's okay to ask for a second opinion. It's okay to do the things that you need to do to make you feel well. If you're not able to live your life, it's not someone else that's going to tell you that that's true or not. You're coming with that truth, and we can validate that. Sometimes medicine can help you, sometimes it can't. But, validate yourself. You're living with this. You need help.
It's a really, really good thought to leave people with. Thank you so much for coming on.
Thanks for having me.
The podcast. It's been an absolute pleasure talking to you.
I was nervous. I hope that was okay.
It's brilliant.
Okay.
If you enjoyed today's episode, please follow and share Patient in the Room wherever you get your podcasts. We'll be back soon with more conversations.